Okay, this is chapter 4, and this is settings for psychiatric care. So we're going to be looking at outpatient, inpatient, lots of other different types of settings in psychiatric nursing. The first thing that this chapter kind of focuses on before he even gets to prevention strategies is the stigma that mental health typically has. So there are many times people will not seek out care, maybe due to shame or anything like that. And so they are not going to seek out care. So mental health champions in the past have tried to make it easier for individuals suffering with mental illness to seek care. So some of the ways that they can do this is outpatient. If they're having a crisis, that might be emergency and going inpatient. There are lots of different outpatient options, but first we want to review these prevention strategies. So primary prevention is typically the first step, and this covers everybody. The picture that's in this slide is looking at how they incorporated this into schools. So primary prevention is system-wide. It's going to cover all children. It's going to be proactive in teaching them whatever they need to prevent the problem. Secondary typically has to do with screening. So they have targeted groups in this area. Usually the kids that are focused on in secondary prevention for screening are at-risk children or at-risk patients or people in society. Tertiary is treatment. So this is usually individualistic and very much based on the current assessment of the patient and making sure that these interventions meet their individual needs. It's not really a blanket intervention for everybody with that problem. So this is a list of some outpatient psychiatric mental health care settings. Of course, primary providers is going to be the first one that we see. This is your typical doctor that you go to for your medical problems. So usually psychiatric illness is noted first at the primary care provider. Usually the patient is coming in for a physical problem, and then they pick up or detect that mental illness at that time. Primary care providers, many of them have the abilities to provide some psychiatric care, but many of them are uncomfortable with that. So they typically refer them on to specialty psychiatric care providers. This usually is a little more efficient for the patient. It's more comprehensive psychiatric care. Another type of outpatient psychiatric mental health care setting would be the patient-centered medical homes. This is very comprehensive. It's holistic. It starts in the house. Then they can assess for the need of emergency care or inpatient care or other outpatient care. So this is usually a 24/7 type of a model where they have lots of resources available to them. Community clinics, I think we're all pretty aware with those, but they can provide emergency services, adult services, and even children's services. Lots of different treatments are provided within these. Med administration, therapy sessions, even group therapy and family therapy are available in community clinics. Psychiatric home care is reserved for patients who are homebound that do have a psychiatric diagnosis and need some of the skills that are provided by a psychiatric registered nurse. And usually they have a very strict care plan that is overseen by a physician. Assertive community treatment. This can be inpatient or outpatient providers. Usually they recognize this because there is a pattern of being admitted into the hospital or showing up to the emergency room. So they're going to get them involved in assertive community treatment. Usually this involves lots of phone calls after 5 p.m., patients that are in need of treatment outside of typical business hours. Partial hospitalization programs. usually is more like a day program. The patient will come to the hospital during the day, but then are allowed to go home in the evening time. There are some other outpatient venues for psychiatric care, telephone, outreach, also some chat type of communication on the internet as well. So psychiatric nursing in outpatient and community settings, this is looking at the abilities of the RN that's in this specific setting. They have to be really strong in their problem solving skills and clinical skills. Many times these patients don't just have a psychiatric diagnosis, they also have medical diagnosis as well. So they have to be able to recognize that. They have to have some cultural competencies. They have to feel comfortable with asking uncomfortable questions. They have to have a lot of flexibility with how they teach and how they provide interventions to their patients. They have to have a pretty wide knowledge of community resources because one resource doesn't work for every patient. So they typically have a pretty wide base of knowledge of what's available in their community. They also have a pretty strong sense of autonomy, meaning they are comfortable with being in charge and providing these interventions for the patient. They provide the psychosocial assessment, and this looks at their housing, their income, their support system, any type of history or current substance abuse, and their overall physical well-being. So that's that psychosocial assessment. They also are involved in case management, so looking at all of the different resources available to the patient for mental health, but also physical health. So they are there to kind of combine both of those worlds. Promoting continuation of treatment. In the past, they've always kind of coined this as non-compliance, but really there are a lot of reasons outside of the patient's control as to why they don't continue treatment. So they've kind of gotten away from that term of non-compliance. But it is important that we provide that patient-centered care and that shared decision making, because that's going to give a lot more buy-in for the patient into their own plan of care. And then these nurses work in teams. They collaborate with physicians, psychiatrists, psychologists, all of those outside resources. So they're kind of that main key person in making sure all these parts are up and running correctly. So you're working with a patient who will be discharged into the community soon. What are some problems that may affect the success of treatment? And this automatically needs to go back to looking at some of those biopsychosocial needs. Do they have adequate housing? Do they have stability in their housing? What is their source of income? Is it enough to meet the need? What is their support system like, whether it be family, friends, support groups, substance abuse history and current use? Usually these are hidden or minimized during hospitalization and really exacerbate when they get out into their own setting once again. And then just their overall physical well-being can inhibit them from having success in their treatment. So making sure that they have good physical activity, that they recognize medication side effects and know how to report those to you, those types of things. So now we're kind of moving into the inpatient side of things. The emergency care center is kind of that middle ground. So the main idea of emergency care and crisis stabilization is to perform triage, whether they need to be admitted or not, provide safety for that patient, and stabilization for them. There are several different models out there for providing this type of crisis intervention. And on page 73 in your book, it mentions 3 different models out there. Comprehensive emergency service model. This is where everything happens within the ED. Hospital-based consultant model. The patient comes into the ED and we usually call in those specialized personnel to meet those needs. Number 3, the mobile crisis team model. These clinicians will actually go out to the patient. So typically after an inpatient experience in the ED, they'll get admitted to psychiatric care. Usually this is reserved for individuals who are harmful or risk harm for themselves or somebody else, or just can't even meet their normal ADLs or their basic safety needs. So usually we'll admit them short term. It could be voluntary or involuntary. So when looking at admission options, we could do direct admission, maybe from a doctor's office, or we could do a hospital emergency department admission. There are certain criteria, like I said, suicidal or homicidal, so a danger to yourself or others, or if you're unable to care for your own basic needs, or if your judgment is so far off that you are not going to be able to make sound decisions for yourself. So there are two different types of admission status, voluntary or involuntary. But remember, irregardless of the type of admission, they still maintain their rights. So their rights, they retain their rights as citizens. They do have a right to safety, and many, I would venture to say, all mental health facilities have a written statement of the patient's right as applicable to the state laws for their specific state that they're providing care in. So multidisciplinary teams, each person is responsible for providing a certain care for the patient. So this is once somebody is admitted into the hospital. There are a lot of people that want to talk to this patient at different levels of care, and sometimes that can get really repetitive in the questions being asked, maybe by the nurse practitioner, and then by the nurse on the floor, and then by the psychiatrist. So they want to really cut down on the repetition of these questions, because it does tend to provide too much of an opportunity for anxiety for the patient. So they have developed what are called treatment plans or clinical pathways. That way there is clear-cut guideline for each person providing care within this treatment team, the questions that they are to ask. That way the patient doesn't feel so overwhelmed with the admission process. We've talked about therapeutic milieu already. This is just the entire setting within that inpatient unit. So the personnel need to be educated on managing behavioral crisis, on providing safety for all of the patients, and recognizing suicide risks. So if we are providing safety for the patients, we also need to be thinking about providing safety for the staff and the other patients in that unit. If we have somebody that is suicidal, verbalizing they're suicidal, they have a plan, even if they don't have a plan, they are going to be put on one-on-one observation. Most of the time in every unit, we have to visualize our patients every 15 minutes on a psychiatric unit. 15 minutes sometimes is too long for the suicidal patient, and they could already plan out their strategy within that amount of time and successfully complete their suicide within 15 minutes. So that's why we provide one-on-one observation of these patients. The other thing that we do to help promote safety is almost every hospitalized inpatient unit is a locked unit, and this does help prevent elopement. That way we can keep our patients even more safe. Now, we do have to remember some patients have the right to leave at their own will, and we can't keep them there or restrain them there against their own personal rights. So if you're looking into being a psychiatric nurse, there are some specific things that we do each time when a patient is admitted. First, we do the assessment. This does focus in a lot on mental health, but also physical health, because they do tend to have medical problems as well as mental health issues. Some of the other things that we do are provide therapeutic groups for our patients. Usually those are timed on the unit. They happen at a specific time each day. They may include family. They may include only the patients on the unit. But we provide those therapeutic groups. There are also other people who provide therapeutic groups, maybe by a mental health practitioner that has some specialized training. That way, it's even more therapeutic. But therapeutic groups often happen 2 to 3 times a day on inpatient units. Documentation is essential, and it is the responsibility of the registered nurse, but also the entire healthcare team, so everybody can stay on the same page for the patient's care. Medication management is a huge job for the nurse in the psychiatric care setting. It's 24-hour responsibility. We do need to have a pretty detailed knowledge about all of these psychotropic medications that we're administering. Not only knowledge that we keep to ourselves and signs and symptoms that we're watching for, but education that we're providing to the patients so they can have a sense of autonomy with their medication and the care of that. So we need to be teaching them about side effects, whether they're short-term or long-term, or if they are even ones that need to be reported right away. So we need to teach them how to recognize, report, and manage all potential side effects and really empower them. This does usually increase treatment success too. Psychiatric nurses also have to stay up to date on their CPR and BLS so that they can provide care to patients during a medical emergency. Many times they also have a crash cart that's available on that unit, usually behind the nurse's station, so that they can provide emergency care to a patient if needed. And remember, discharge begins the second our patient is admitted, and it is continually changed to meet the need of that individual patient. We do typically focus on, though, when they're in the hospital in an inpatient setting, learning new coping skills and behaviors that will help them stay away from those crises in the future. And an inpatient unit is a great place to practice some of those techniques. So our first question here asks, an occupational health nurse screens factory workers for depression. Which level of prevention is applicable to this activity? So let's not answer D. Let's not be not sure. At this point, remember, we're screening. So screening typically involves those who are at higher risk. So screening is always one of those secondary levels of prevention. And this is our last question for this chapter. A hospitalized client is diagnosed with major depression, tells the nurse, "I need my belt to keep my pants up. They keep falling down." Which response should the nurse provide? Now, hopefully you've picked up on a red flag here in this question. Most patients on an inpatient unit are not allowed anything like a belt, shoelaces, anything like that. Especially if we have a patient that's majorly depressed, they may be thinking about suicide. So let's look at these options. Excuse me. A, your belt is locked in the business office for safekeeping along with your other valuables. This is probably a true statement. B, for safety reasons, hospitalized clients are not allowed to keep certain personal possessions. Also a true statement. C, I cannot provide your belt, but I will help you get some pants with an elastic waistband. This does seem like a viable choice as well. And then D, I will ask the psychiatric technician to get your belt for you. Well, obviously D is incorrect. We're not going to give them their belt. A and B are very similar responses. It's saying, yes, we have your belt, but you can't have it. It doesn't really provide an appropriate response for our patient to actually help them out. C does provide the answer, I cannot provide you your belt, but it does give them further direction. I can get you some pants with an elastic waistband. So we do have to look at what's appropriate for our patient, and at this point in time, this is an appropriate response. If you guys have any questions over this chapter, please feel free to send me an email and we can address those.